What can the EU do next? We've talked about the fact there is new money available. There's a new political focus on cancer. There's a willingness for the EU to step up and do things as never before. In the post-pandemic environment, the EU added value to health systems is clear. And countries who only a year ago would have said, I don't think Europe has anything to say or to offer my health system, it's now very clear that Europe is a safe space, a safe harbor to explore how to meet the gaps and challenges that exist at national level. And it's also clear that unless we share the data, we don't have a full picture of what's happening with our population. So here's to help us discuss these final questions. Let me introduce you to Dr. Chiara Nicol, the Head of Unit for Health and Society at the Joint Research Centre for the European Commission. Ivar Ijabs, a member of the European Parliament and Vice Chair of the European Parliament Special Committee on the Beating Cancer Plan. He's from Latvia. We have Professor Dr. Stephen Halloran, who is a colorectal cancer screening advisor to Public Health England and Emeritus Professor at the University of Surrey. And we have Dr. Kalin Bumbulut from the European Union of General Practitioners. And of course, we talked about the role of GPs earlier today. So panel, got lots of expectations. Let me just again sum up some of the elements that came from the earlier conversation. We need long-term sustained funding, not just a 3-year, 4-year initiative. We need a mechanism that brings together across the different cancer areas that we do screening, so that we can, so it's initially it would be cervical cancer, it would be breast cancer, it would be prostate cancer and colorectal cancer, maybe enlarged later, to say, you know, how do we ensure that we manage, because they may have similar or different invitation levels and mechanisms to different parts of the population, to make sure that the whole population is both literate in the need for prevention, the importance of screening, and is a willing and active participant in all of these. So, shall we start with Dr. Chiara Nicol? What would you like to share here? Lots of expectations about what the EU could or couldn't do.
Good afternoon, Tasmin. Can you see and hear me, first
of all? Yes, we can.
Excellent. Good afternoon, dear colleagues. And first of all, I'd like to compliment DICE, Digestive Cancers Europe, for this excellent summit. It is really very timely and it's so encouraging to see so many parallels, so many areas for complementarities, and that we can really now start working together like never before. And yeah, Tamsin has also nicely summarized the history before when it came to guidelines and whatnot. But indeed, if there's anything positive about this horrible COVID-19 pandemic, it is now bringing a new impetus to health, and people are beginning to see the value of working together, to not reinvent wheels. And you've been mentioning many aspects like long-term sustainability, etc., etc., and these are really important. Now, very briefly, I work with the European Commission's Joint Research Centre, and in our unit, we take care of the European Cancer Information System in collaboration with the International Agency. This is with a network of 150 cancer registries, and we also develop and provide European guidelines and quality assurance schemes for improving breast cancer screening, diagnosis, and care. Now, I'm mentioning those two activities initially because we exist since 1957, Treaty of Rome, and I do expect we'll be here, I hope, for another 50 or so years. So the platform systems, portals, and gateways that we have built up here are sustainable in that respect, but we still need to join the dots together. This is really, really important. First of all, just to give a little bit of the background in the Commission, indeed, our colleagues in Santé, and we're working hand in hand together, basically very closely together to develop the Europe's Beating Cancer Plan, and that is moving on. So early next year, date has not been precisely pinned down, but that will be launched in probably end of January, February next year. Meanwhile, the mission on cancer is under development. We're in collaboration with them too, through the mission board. 13 recommendations is what they're coming out with, and all very clear, including screening, etc., etc. Previous colleague mentioned the European Health Data Space that will be launched probably end of 2021. And in the meantime, I have some, I think, very positive news, because we in the GRC have had we developed a concept for a knowledge center on cancer, again, a sustainable entity And this knowledge centre will serve the Europe's Beating Cancer Plan, will serve the recommendations of the Mission on Cancer, and will serve the European Health Data Space. And you often question, why? Is it just another entity? Don't we have enough of them? Well, actually, this is about bringing and fostering coordination at the scientific and technical level. The GRC is kind of unique in the Commission that we are not a political DG. We provide this independent scientific and technical support. Independent means independent of all commercial, private, national interests, but also even independent of individual DGs, because DG research will go in the direction of research, environment, agriculture, agriculture. Sometimes some of these political directions can conflict, let's say, with or slightly conflict with a holistic approach to tackling cancer, because cancer is multidimensional, multifaceted, and it's time to bring all that together. Hence, the Knowledge Centre on Cancer has been endorsed by Commissioner Gabriel on the 5th of February this year, and that will become a, let's say, a connection point, bringing many elements together. So I think that's an encouraging aspect coming up. Now I'd like to zoom in a little bit closer on European guidelines. You know that the Commission has been involved back then with the International Agency for producing guidelines for breast, colorectal, and cervical cancer. Screening and diagnosis was what we did in the past. The booklet was produced, etc., etc. In the last 4 or 5 years, the GRC became involved in this. And I'm happy to announce that the European Commission initiative on breast cancer is nearing completion. Basically, what we have in place there is we have developed the recommendations for screening and diagnosis. And then we have systematically reviewed and provide a platform of guidelines internationally recognized, the best for covering the whole pathway. On top of that, we've created a quality assurance scheme with quality indicators, which will be the vehicle for implementing the guidelines in the member states. Now, this is not about state of the art, the best, as Tamsin mentioned earlier. Oh, some countries might say we're already beyond that, we're better than that. This is about improving minimum standards. It's about ensuring the patients don't fall between the stools of the healthcare pathway. Basic criteria that can be implemented across the board throughout the European Union, despite its diversity in its healthcare settings. Challenging, but we're finishing it now. Already 12, 13 countries, even though it hasn't been finished, are implementing those guidelines in some way or the other. For example, Tunisia did an international review of all best guidelines, and they decided to adopt the European Commission guidelines. In any case, you have China in there too, whatnot. It doesn't matter. In any case, what we have is really, really useful. And what's important is that we go towards from development to implementation. And you will see now with the Europe's Beating Cancer Plan and the Mission and the new initiatives, and we will see in the future the role of the European Union in health, but we will go more towards implementation in the member states. Because you can have the best guidelines in the world, but if you don't implement them and monitor them and demonstrate that they work, well, then where will you go? But the European Union may be able to soon do something like that. So yeah, that is about to finish. And finally, and I know Yola will be happy to hear this because Yola has been visiting us for years talking about the European Commission initiative on colorectal cancer, and then now Stefan, and it's fantastic to work with you all. But basically, we are now progressing and we're about to start with the colorectal cancer guidelines. So the latest news from actually last week is that the Commission's SecGen has approved the establishment of European Commission initiative on colorectal cancer executive. This is a special group within the Commission, and then there will be an open call, and I'm glad that all 140 or 50 of you are listening, because there will be an open call for experts then based on that. We have learned a lot of lessons after the experience with breast cancer. So this will be much more efficient, and it'll be faster and less, let's say, less bureaucratic. Because in the past, and it was new to us, we had two large groups. A guidelines development group, 35 members, experts on guidelines, a quality assurance group, 35 members, experts on quality assurance, and they worked sort of in a way separately, but yet together. So in any case, we will be going full steam ahead to get the colorectal cancer guidelines out there. And some more good news is that we update these guidelines in real time. In the past, and it is not a criticism, as soon as guidelines were produced, well, they were basically out of date because evidence becomes available in real time, more or less. So the breast cancer guidelines are actually being updated, even though we've produced them recently as we speak. So it won't be like every week or so to be updated. It takes time, as you know yourself, systematic reviews, the grade pro or the grade procedure, evidence to decision frameworks. It's a very, very thorough process, so it takes time. But in any case, there will be no more, let's say, out-of-date guidelines in the future. So yeah, basically we will start this next year, and we will be also producing a reserve list of experts. So expert reserve list will be updated if and when and as needed. So I think the future in terms of the whole cancer domain looks positive from the EU's perspective, and Tamsin, I will finish here now, but we will see what the coming weeks and months bring. Basically, we all know that COVID-19 has had a detrimental effect. I don't think we even know yet how bad on the whole cancer even screening, diagnosis and care paradigm, with some cases 3-4 months delays in screening programs. And yeah, okay, but at least if we come together, and what Europe really needs to do now is to bring all these entities and activities together. We need to all talk to each other at the very, very beginning. That was one of the reasons for the Knowledge Center, so that we don't plan something in splendid isolation and go ahead and then realize afterwards, oh, this guideline doesn't fit with that setting or whatever it is. Coordination, working together is the key. And I don't know if we need to produce something new. What we do need is we need to capitalize on what we have and to use that together. Okay, I want to stop there. I guess it's about time. So yeah, thank you again to the organizers, and excellent moderating there, Tamsin, and that's it from my side. Thank you.
Well, thank you, Kieran. I've taken a page of notes from everything you told us. There was a lot of detail in it and very interesting. I suppose for the audience, the very exciting new news is that there will be a go-ahead for an initiative on colorectal cancer. So there's a tremendous opportunity to do here. And I think it's also very appropriate that you have started to put the focus now on implementation science, because as you say, guidelines are no use if they sit on a shelf. And the message that I hear when I speak to people in health is, yes, of course we've got guidelines, but we neither have the staff or the facilities or the technology to actually make it happen. So if there is now going to be an approach that looks across the system to see how these guidelines get into practice, and as you say, you know, it takes on average 10 to 15 years for new research to enter into guidelines and then into practice. If there's a way of speeding that up, I think that's really valuable. I'll give the audience an opportunity to come a little bit later, but they're happily chatting away, lots of input coming in there. But let me move on and invite our next speaker, MEP Ivar Ijabs, to share their views from the European Parliament. Of course, the Parliament has been a strong supporter on cancer. It has established its own intergroups on cancer and has put out its own reports on the mission for cancer. So, Mr. Ijabs, what would you like to share?
Yes, thank you very much, and thanks for inviting me, because I think that this exchange of views really contributes also to the debate that is going on in the Parliament and the Special Committee on Beating Cancer. Well, as for the colorectal cancer, I think that this is a very good example of the sphere where the joint European action is needed. Because it is preventable and it is healable on the condition that the European countries are capable of acting together in many spheres, starting from screening to, well, survivors rehabilitation. Well, of course, we all know that despite the fact that, well, the COVID has changed things without any doubt, well, the health will remain, at least for a while, the mainly national competence. But nevertheless, in the prevention and healing of colorectal cancers, this is a clear example of what we call sometimes the European value added, starting from a unified approach to screening, to data collection, common research and treatments and medicines, in policies regarding lifestyle factors. And in that sense, these are the spheres that we are also trying to develop and to push forward. In our report, we are working in the European Parliament in this Beating Cancer committee, which is also trying to promote not just, let's say, some kind of abstract guidelines, but also some concrete policy proposals. One of those proposals is dealing with an issue which is the health inequality in terms of cancer among the European countries. Because, well, of course, inequalities in access to colorectal cancer screening exist across countries, and many European citizens are excluded from access to screening programs. And this is a basic problem. But nevertheless, well, to promote a common European approach, we still need some kind of a common institution and common approach, which is this idea of the comprehensive cancer centers being located in each and every member state, not just dealing with medical problems, but also providing information and providing data. And that's why I am also very happy to hear that the project of the Common European Health Data Space is moving forward. Well, what are the priorities that could be done right now by the European Union and the European institutions? First of all, I'm from Latvia myself, and I'm, let's say, a good colleague with Professor Marcis Leja, who is also the only member of the Cancer Mission Board. And I trust him in the sense that the issue of the quality screening and the quality assurance in colorectal cancer screening is really a basic problem which should be dealt with somehow by using those common European standards also for the further exchange of information. And in that sense, I think that what was said by the colleague from the JRC was really an extremely good thing, that the Commission is moving in that direction, and we will probably see something like that. Also, well, the data space, the EU level awareness raising campaigns on lifestyle factors that are causing the colorectal cancer, aiming particularly on well, younger people, not just those people who are over 50 who are, well, directly subject to the threat of colorectal cancer itself. Also, the best practices in dealing with this type of cancer and the provision of knowledge. And in that sense, I'm working in the European Parliament very much with the Horizon problem and all the research-related programs. I think that this program could play an important part, and I'm not just talking about the cancer mission, but also some other partnerships, also the European research program, and also, of course, European Institute of Innovation and Technology, which also has its health dimension and health kick, as we call it. This is important also because, well, it is extremely important to get all things focused, all the programs, all the agencies focused on a common work, because there are, well, the fragmentation is still visible, that we are having the EU for Health, we are having the Beating Cancer Plan, we are having a Beating Cancer Committee in the European Parliament, and so on and so forth. Well, I think that one of our tasks is to get these things to work together. And also, well, since health still remains the national competence and will remain so, at least for a while, it is extremely important to nudge the member states to get invested also in introducing these nationwide population-based cancer screening programs. That this is an issue. How do you deal with the structural funds? How do you deal with the European funds to nudge countries to invest in those programs and to make them as efficient as possible? So thank you very much. I'll stop here.
Thank you. And it's good to hear the strong commitment of the European Parliament to making this happen at European level. And I think there's a long way to go to make sure that what looks good on paper is actually good in reality. And I'm thinking of the European cancer registries, and of all the disease registries, the cancer community is much further ahead than the other disease areas. And already within that, if you look at the national cancer registries, some of them haven't been updated for 10 years. Some of them, they have only very basic information. They don't have information at what stage someone is diagnosed and prognosis. So we cannot get the benefit of the information sharing unless the quality of what's input is consistent across the different countries. So it's not good enough now just to have every country have a cancer plan and say that they've got certain things in place. If we're going to fully federate that information and to achieve the leap forward we need, then we have to pay attention to actually how it is done at national level. And the EU taking a sort of greater leadership role and providing the necessary funding and technical support for that to happen is very welcome under the various cancer initiatives. Okay, let me now pass to our next member of the panel, to Stephen Halloran, who's got, of course, advisors in the UK at the Public Health England as a emeritus professor in this, with a specialisation in colorectal cancer. What would you like to see happen for the next few steps at EU level? What could the EU do to achieve a real step change in this?
Well, thank you very much, Tanzin. I have to say that across Europe, we've probably got more screening in colorectal cancer than anywhere else in the world. And yet, across Europe, we've got examples of the very best in screening, and probably quite a number that would be not good examples to the rest of the world. And we've got a number of countries who have still not managed to get screening programs up and running. So overall, I have to say, I feel really impatient and frustrated by the progress that has been taken since I became involved with screening, and particularly with the European activities. We need clarity from Europe as to what is expected of individual countries. Gathering data is important. Accumulating information about what people are doing is important, but there needs to be clarity of what should be expected of individual screening programs. This clarity needs to be considerably more ambitious than people are working to now. We have heard today of some of the most impressive screening programs in the world. And those are the targets that we should be aiming at, and we should be trying to reach. We have the tools, we don't have the ambition. We have the expertise, but we don't use it as well as we might do. We need to tap into activities such as Utopia, that is doing a great job and was illustrated rather well by Iris. We have a growing awareness of the importance of quality in colonoscopy. Some countries have adopted these new standards, and others are currently closing a blind eye to it. Those standards need to be there. We talk about participation rates, and we talk less about coverage. So there are programs that are hailed as being good programs because their participation rate is okay, but then you discover that in fact it's only getting to a relatively small proportion of the country. So this area of mediocre activity needs to be under scrutiny. And that requires, I think, the EU to take a less compromised and a more ambitious stand and clarity as to what it would expect each of its countries to be achieving. I say this, of course, as somebody in the UK who sadly have chosen to pull out of the European Union, which is a rather sad position as far as I'm concerned. But the country needs the country needs to learn and continue to learn from Europe, and we need to tap into the expertise that currently exists. Tanzin, over to you.
Thank you very much. And I share your frustration in the sense that some of this progress seems to be going quite slowly. And when we've discovered the gaps in some of these areas, actually, there is no mandate to force change at European level. You can highlight, you can illustrate, you can index and benchmark, and so you can, but the pressure for change has always up until now had to come at national level or from the stakeholders within their system by seeing where they are in a ranking. I think this is one of the Commission's greatest soft powers, is to provide some kind of ranking that allows domestic pressure in the countries to the bottom, that is to say, we are underperforming and we want to move up the process. But that's a very slow incremental process, and it's not fast enough for what we want to achieve. So snail's pace is what somebody's put in the chat. It's not just slow, it's snail's pace. And if we're going to achieve what some people are talking about as a moonshot, these ambitious goals for the Beating Cancer Plan, we can't afford to go at that pace. So now let me move to the last speaker in our panel here, Dr. Kaylin Bumbulut from the European Union of General Practitioners. Now, we heard earlier from some of our presenters that leaving screening just to GPs to be the initiator doesn't allow us to reach the maximum of our population. However, integrating within the care that primary care physicians offer to their patients, the importance of screening, information about it, explanation of diagnosis, the follow-up, the recommendation to go for colonoscopy, this part is really critical to making it all work. So let's hear from you, Callan. What do you think the EU could be doing to improve on this situation?
Thank you very much, Tamsin, for the opportunity. I'm the last, but I hope my organization is not the least in this row. Of course, I'm just kidding. Short presentation. My organization, UMO, the European Union of General Practitioner Family Physicians, reunite the most representative national organizations representing, of course, general practitioners in the countries of Europe. We are founded in 1967. And now UMO comprises 25 countries representing over 400,000 family doctors across Europe. As you already mentioned, the topic of the importance of GPs in colorectal cancer screening has already been addressed in one of the previous panel, and I would not want to that the participants to be left with the impression created by a unilateral discussion. Of course, I respect all the opinions of the participants, but family doctors are not part of the problem, but part of the solution. As I have heard in Finland, family doctors are not involved in the screening program at all, but nurses. But I think it's a little bit of confusion of the term of primary care, which actually includes nurses as well, who are in the coordination of family doctors in most countries of Europe. In addition, the success of a national screening program can be undermined by the issue of rural areas with limited coverage of medical services, which are often provided exclusively by family doctors and their primary care team. In fact, there is a great variability across Europe regarding the level of economic development and implicitly of accessibility to medical services. In the most developed European countries, the differences between rural and urban area are not so big, but usually without the participation of family doctors, no national screening program can be successful, especially in countries with large population. The opinion expressed on chat that family doctors are not reliable in a screening program, and here I would not like to limit myself to the one for the program for the colorectal cancer. Is unusual, at least for me. Regardless of our workload, even in the pandemic, GPs have a fundamental role in promoting health and preventing diseases. The family doctor's effort to encourage the population to test is vital to improving the screening rate. Most individuals consult their family doctor at least once a year, but statistic has shown that at the EU level, the average addressability to the family doctor is 5.5 times a year for every citizen. So we are talking about 2.5 billion consultations per year in primary care. Studies have shown that many of the individuals accept testing if it is recommended by their family doctor, even if they are embarrassed by this procedure. In order to encourage more people to take the test at set intervals, it is important to consider the reasons for not accepting the test in order, of course, to influence them. So briefly, sorry for this, it's not so briefly. Primary care is the, how to put it to be politically correct, the piece of resistance for the complete success of a screening program through inviting and informing the population, performing the first stages of the screening, referral of cases either in order to perform the detection test or in order to monitor the abnormal results, communication of screening test results. Of course, we are ensuring that the pathological results are carefully monitored over time, and the family physician verifies the reason for not accepting the test. There are, of course, European guidelines for quality assurance in colorectal cancer. There's not only in colorectal cancer, of course, screening. Based on the Council recommendation from December 2003, but they are not updated from 2008. I have heard from Dr. Nicol that they are now under review, which is a very good news in terms of coordination policies at the European level. And I think I must conclude now because I occupy a very, very big part of that slot of time. Thank you.
Thank you, and thank you for sharing your view. And of course, I don't think that anyone was trying to say that the GPs were unreliable, but I think the point might have been trying to make that if they are the only frontline that's responsible for doing it, then there will be gaps in the system because not everyone sees the doctor and they're already overloaded with many things. To make sure there are multiple channels to make it happen. Let me just come back to Karen, because I think it's very exciting that there's going to be a new initiative and a new knowledge centre on cancer within the JRC. But to what extent is that going to deliver the kind of multi-stakeholder approach that we heard earlier is so critical? So, you know, I've sat on a few of these expert committees myself for the Commission, and I've seen them. They have a small number of people who are always the great and good, who are on this board and that board and who we see everywhere, but that doesn't actually capture the kind of, you know, patient, slow relationship building that we've talked about all day, which is about building the trust of the stakeholders, having patients and their families connected with, you know, frontline nurses, connected with researchers, etc. So is this going to be an IT information clearinghouse? Is it going to be a walled garden where the great and good, just like the mission plan and mission board and everyone else is? And what happens when you have those is people fight to have the seat because it's all about being visible on the seat in these boards. But then you don't have the kind of outreach that's needed, and these expert groups have to follow the rhythm and timing of the European institutions. Everything has to be approved and take time. So it becomes an institutional elephant / monster rather than a sort of agile learning community that's flexible and open to others. So can you just give us a little bit of insight on what your vision for this knowledge centre would be?
Yes, absolutely. I mean, first of all, I think you mentioned it earlier, Tamsin, that in the past, the health focus was very limited, knowing that we didn't have a mandate in the member states of the European Union, and we still do not. But in time, that will become, who knows, that may change because working together makes sense across the board. With regard to the Knowledge Centre in Cancer, well, its whole purpose is to connect the scientific technical components of all cancer-related activities in the European Union. So basically, that should mean that planning and execution of tasks related to cancer will be done in coordination with other initiatives. Now, in terms of the European health data space, you will be looking at things like, of course, also artificial intelligence, machine learning, trying to combine all the data sets in a kind of a knowledge management approach. So far, I must say that the development is going very well in terms of we are linking concretely to the Europe's Beating Cancer Plan in terms of what we do on cancer prevention, where we focus mostly on nutrition, and there we have a knowledge gateway, which is a reference point for Europe and for the world on nutritional aspects, which for colorectal cancer is super important. Physical activity too, but less on that. Then we have the guidelines for screening, diagnosis, and care, covering the whole pathway. This is based on the most robust, internationally recognized methodologies out there. So this is solid stuff, let's put it like that. And then we have the European Cancer Information System, which was mentioned before. And by the way, Ireland does have a cancer registry contributing to the European Cancer Information System. Maybe to say a few words about that in terms of concrete things again. In the European Cancer Information System, next steps will be to include pediatric cancers, not so relevant for this summit, but still very, very important. We will be introducing cancer staging, very relevant for this project, because staging is so powerful. You know it better than I do. Stage 1 colorectal cancer, 90% survival, I believe, which is really something we need to catch. Yeah, we have to catch it early. We'll also be geographically positioning the data. Now, this means this will unleash a whole new paradigm in terms of linking up with environmental indicators, and all this is mapped in the knowledge center, like combining lung cancer with particulate matter 2.5, radon with lung cancer, pesticides, polycyclic aromatic hydrocarbons, socioeconomic factors as well. And then, of course, we have the behavioral aspects, which I do believe has a very important role to play when it comes to screening hesitancy, like you have with vaccination hesitancy, etc. So there's no clear, solid answer, but I can see now in the Commission, and I'm in it quite a while, that there's a great commitment to working together. DG Santé and RNI have been designing their plans and missions together with us in the middle as well. In the past, that was more or less done separately. So even now, what we've mapped in the Knowledge Centre in Cancer, it links up to activities in 15 different departments in the Commission. 15. So basically, these are activities that are either directly or indirectly related to cancer. So I think the momentum is about to come, and what will be important is that we again work together and make sure we plan and design at the very, very early stages together. That we bring in the stakeholders at the early stage and not go running down the road to end up with something that again will be isolated and not contributing to the overall benefit. I will stop there now, Tamsin, and I hope that helped to answer the question.
Yes, it does. I mean, I think it's again been recognised in the chat that it's important to connect the people in the field with the Institute or this new clearinghouse. I think you've done an excellent job at describing some of the complexities even within the European Commission with the best will in the world. There's so many pieces of the puzzle dealt with in different places with different legal mandates and different objectives. So just mapping it out and getting them all connected is an enormous task. So we expect to see some momentum coming in from that. But how does the people from the outside feed into this and contribute and are part of it, particularly the people from the field, the patients and others? How do they engage in a way that's different from just having a sort of small representative group who advise? That's great, but it's not going to get the momentum that you need.
Yeah, well, with all the projects we're conducting here, none of them are done in splendid isolation. Believe you me, you have the massive stakeholder networks I mentioned for the European Commission Initiative on Colorectal Cancer. That means the new guidelines, which, by the way, will not become out of date. There will be expert groups, open call, etc., etc. We have patient advocacy groups and patients in the expert group. So for the European Commission Initiative on Breast Cancer, of course, Europa Donna and at the highest level, we're there all throughout the whole development process, and we have patients involved too. So in developing the recommendations, the patient perspective is of course very important. And then all the stakeholder communities. But in Europe alone, we have so many entities, societies, you name it, working on the things. And there is also a challenge to pull everything together. So while one can do one's best to connect with everybody, if you would ensure connecting with 100% of all the people who are working on the cancer aspect, then you're would probably do nothing else, because it would take a lot of coordination. But I think what's important to do it is in the areas that you're working in, to make sure you have those connections, and that we do. So for all our projects, of course, it's the stakeholders, the member states, etc., are involved in the process. Yeah. You're muted, Tanzan.
Thank you. Mr. Japs, if I could come back to you. In the chat, we've had some input from people from different countries, mentioning Romania, mentioning Croatia and others, showing that there are quite big gaps between what officially needs to happen and what's happening on the ground, the level of, for example, digitization of records, and the level of outreach and actual ability for the population to engage in these things. In the European Parliament, are you aware of just how different things are on the ground from perhaps some of the more rosy pictures that are given by national agencies when they're telling the European Union everything's fine and they're meeting the targets? The stories on the ground are quite different. How does the Parliament see its role in trying to make sure that they don't just take the word of governments on their targets, but are actually hearing the messages from the communities and patients?
This is a fair question, without any doubt. First of all, yeah, well, that's why we are elected from 27 member states to be dealing with such problems. As far as the compatibility of data, it is enough to talk to researchers and to doctors themselves to discover that this let's say, common standard and common approach to health data is still very much missing. But, well, this is probably not the only thing where we can see this fragmentation. To my mind, there is also an issue when dealing with countries like Romania, Hungary, or Latvia. This is also the question of medical education, which hasn't been mentioned until now, because we know that there is a certain brain drain, or if you want, as a skills drain for medical doctors going abroad. And this is how, well, these health disparities among countries are growing sometimes. Of course, this is a structural problem which just can't be solved in the framework of one beating cancer plan or whatever, but this issue should also be taken into account, where people who are dealing very well with colorectal cancer, for example, here in Latvia, they are just leaving, and well, new doctors are not educated in suitable quantities, which means that, well, yeah, but as for the compatibility of data, well, the colleague in the previous panel said something about the well, misinterpretation of the general data protection regulation. This has unfortunately been the case, that the GDPR is an extremely helpful instrument if you are able to use it in a proper way. But from the point of view of a normal, well, civil servant, it's always a danger to get involved with that particular regulation. And this is how those data are stored somewhere, but nobody knows how to access them. So thank you.
Okay, thank you. I can see that we're coming towards the end of our time together. So let me invite all of our panelists to just give us their last few words about where they see the EU having added value. I began this this panel by saying, we are at a unique moment in European history in terms of health. And remember, the history of the EU working in health is very new. It's about 20 years old. I mean, it wasn't until 1992 that we got an article in the EU treaty with the word public health in it. It wasn't until 1999 we actually had a department of the Commission, a DG with the word health in the title. So, I mean, over the past 20 years, there's been a sort of absolute revolution. We've got agencies that deal with communicable disease now. We've got a food agency, and we're about to get another new agency looking at research and development. So we have, we're 20 years old in our sort of approach to health at European level, and much of those the progress that I've seen, because I started working on health at European level in 2002. So I've seen the up and down of the roller coaster, and it has been very crisis driven. A crisis approaches and we realize we need more health, we need to collaborate, and we sometimes reluctantly, put in more access. I think we're at a moment of transformation, and this is a game changer, because it's the president of the European Commission who is leading the charge, who's saying the union has to be a union of health. If not, we're not delivering for our citizens. She is the one who's laying down health as being one of the central elements by which you judge the functioning of the EU project. If citizens are not protected for their health, then Europe is not delivering. So I think we've got a window of time. And if you already see in the first 12 months of its mandate, the amount of sort of new legislation, new proposals coming forward on health is, for me, very exciting. Because it feels like for a long time health was a Cinderella issue. It was a directorate that was exiled down in Luxembourg. It had little money, little power, little focus, and suddenly here we are. For better or worse, health is on the political agenda. So I think the stars are aligned for us to make huge momentum if we can get it sort of really going, get all the stakeholders behind it. So having said all of that, members of the panel, what would you like to see as the EU contribution? Just 1 minute, your top 2 or 3 things that you'd like to see the EU do. And Karen, I'll start with you and we'll go in the order that we went.
Thank you, Samson. Yes, absolutely. What I'd like to see is more implementation and more monitoring. Basically, I think we've produced a lot of best practices and guidelines are best practices. We're empowering data, we're enriching data sources, we're trying to link up the data, bringing in AI, machine learning, you name it. But we need to, what good will it all be unless it has an impact on the ground? That means in the member states. So I think, and this is a direction I know about politically is happening. Infrastructural funds and mechanisms are being mobilized as we speak to jump into the health game. And it's a serious game. It's so important that it's back on, well, it's on the agenda for the first time, and saying 20 years, times what makes me feel young. No, I think the prospects are bright, but yes, implementation, impact. That's where we need to focus. Thank you.
Excellent, thank you. Mr. Ijabs.
Yes, well, some of the things have been mentioned before. First of all, well, the common data space, without any doubt, also regarding the machine learning, artificial intelligence. But, well, I just wanted to mention the thing that we are fighting for in the European Parliament. These are those common entry points in the European cancer treatment systems that are right now called the comprehensive cancer centers, which should serve as a basis of a common European approach to the cancer. And also, just as I said, nudging the member states get involved in the screening. Thank you.
Excellent, thank you. Okay, Stephen.
Thank you. Well, what I'd like to see is in a year's time, a meeting such as this, which I think has probably been unique in its ability to bring together people from a range of backgrounds. And for that meeting to hold the Joint Research Centre accountable for what progress it has made during the last 12 months. And I'd like that process to continue annually so that we can work to new high standards of achievement and ensure that the EU is making the progress that currently we're told is on the cards. Thank you.
Thank you. And Calin.
Thank you very much. In our belief, for planning and implementing an organized program, screening program, it's needed informed decision to initiate the screening program, political will, with, of course, financial support from the Ministry of Health, program developed by the public health authorities according to a national policy based on a predetermined strategy and, of course, on the European guidelines. And in our opinion, despite other opinions, a primary health care with a role and essential contribution. And the key word here is that the success of a colorectal cancer screening program depends on the all specialized staff involved in implementing, providing, and evaluating an efficient and quality health service.
Excellent. Thank you very much. Well, I think our panel, I think you would all agree, has given us a really lively and very broad-ranging approach to EU, highlighting how this is a special moment in history, and there's a lot of things that have been developed over the last years that are coming to fruition, and that now we are at a jump-off point to move to the next level. So I would say watch this space, and hopefully in 12 months we'll be coming back again to have another event, bigger, better, possibly in person, where we're able to report on progress. So can I give a warm thank you to Karen, to Ivaz, to Stefan and Kalen for sharing their views and their perspectives on what the EU could contribute. And I will close this panel